Hello, everyone. Welcome to Everything You Ever Wanted to Know About ALS and the Veterans Administration. Before we begin our webinar today, I wanted to let you know that you are muted and not on camera. So please relax and enjoy the presentation, which will last for about an hour. You will also notice a chat box in the right of your screen to enter questions for the Q&A session after the presentation. Lastly, this program is being recorded and will be available to view on our website in the next week. So let's get started. I am Lauren Webb, the Director of Support Services and Education at the Les Turner ALS Foundation. Thank you for joining our ALS Learning Series with Dr. David Kvarnberg from Edward Hines, VA. Before I formally introduce you to Dr. Kvarnberg, I'd like to tell you a little bit about our sponsors and the foundation. The ALS Learning Series is made possible in part because of a grant from the Gilbert and Jacqueline Fern Foundation and our industry partners, Cytokinetics, Control Bionics, and Mitsubishi Tanabe Pharma America. We are leaders in comprehensive care, personalized care, and we believe that it's really important to help patients living with ALS so that they don't feel overwhelmed or unsure of what questions to do or questions to ask next. I think my screen is not quite lining up, but we'll continue. Oh, there we go. So those are our sponsors. And the next slide is that we're leaders in comprehensive care and research. So I wanted to tell you a little bit more about our support services. Our support services team is comprised of knowledgeable and compassionate nurses and social workers with many years of experience guiding people living with ALS and their families. We offer a variety of services, including care visits through our ALS support service coordinators, support groups, and we connect people with community resources, as well as offering different grants. At the Lois and Sulliel ALS Clinic at the Northwestern Les Turner ALS Center, we offer access to enrollment in clinical trials and a multidisciplinary team to provide comprehensive support. I also wanted to make sure that folks are aware of our decision support tools, our guides, and our webinars, which were created to provide clear and relevant information to help people living with ALS to make informed decisions and to help improve healthcare outcomes and hopefully reduce caregiver stress through the ALS journey. Please visit lesturners.org/resources. Thank you to all the veterans who've joined us today. You've been leading the fight in educating the public about ALS. I want to share a short video clip of Nicole Sammartino talking with Bob Ives, a veteran living with ALS, about his relationship with VA. The rest of Nicole's interview with Bob will be posted on our website next week.
During the building of the Berlin Wall and the Cuban Missile Crisis. Both these traits have served him well since his diagnosis. Bob and his wife Mary are active in our Chicago support group and are dedicated donors to the Foundation's research and support services program. Bob is joining us today to tell us a little bit about his relationship with the VA and how that relationship benefited him directly as a veteran living with ALS. So Bob, tell me a little bit about your relationship with the VA and how it started.
Thank you, Nicole. Actually, my service time was back in the early 60s, and part of the way I worked my way through college, and I benefited from the experience, but I put the service in my rearview mirror until 2015, when my Les Turner advocate, Eileen, asked if I was a veteran. I said yes, although I hadn't considered myself a veteran because I never saw combat and never was posted outside the U.S. So it was through Eileen that I found the VA offered some help to veterans who were diagnosed with ALS.
Very good. Thank you, Bob. Yeah, and that's what our support services coordinators are for, right? To make sure that you are aware and the people that we serve are aware of the benefits that we do offer and that we can link them to. So how did you benefit from the VA? Were there any specific benefits that were particularly helpful to you?
Yes, there were. First of all, as you heard, Dr. Kvarnberg, or Dr. K, to us regulars, has put together a very competent staff to work with ALS folks.
You'll be able to hear more about Bob Ives' story, and we'll post that later. And I just want to thank Bob Ives for his kind words about Dr. K's team. We know that's echoed by many veterans here in Chicago. We also know that we have folks from all across the country joining us today. And so I wanted to take an opportunity to introduce to you Dr. Kvarnberg. Dr. Kvarnberg received his medical degree from Rush University. As a medical student, he was recipient of the Navy Health Professional Scholarship, which led him to serve 4 years of active duty as a Navy physician, and it included 2 deployments to Iraq with the Marines. He then received his neurology residency and neuromuscular fellowship training at the University of Illinois in Chicago. He has worked at the Hines VA since 2012 and has been the clinic director of Hines ALS Interdisciplinary Center since it started in 2013. Since 2022, he accepted the role as acting chief of the neurology service at Hines. In his free time, he's an avid hiker. Please join me in welcoming Dr. Kvarnberg today. So with that, I'll pass it off to you.
Okay, thanks, Lauren. Yeah, thank you for having me. This is quite an honor for me to come and talk about my 2 favorite things to talk about, veterans and ALS. Although I was just kind of getting into hearing Mr. Ives talk about how great we were. He kind of got cut off, and I wanted to hear more about how great we were. But I'll save that for the end. You guys can look at that and look at that on your own time. So let me share my screen. So, okay, I believe my screen is shared. And if it's not, then maybe Lauren lets me know and interrupts. But anyway, this is what we're going to be talking about. I have to admit that my title is a little bit of an exaggeration. It says everything you ever want to know about the ALS and the VA. And we're not going to talk about everything. We're going to talk about some things. And I'm happy to take lots of questions at the end. If there's more questions, maybe I can give answers. But what I wanted to go through is I wanted to talk about what's this connection with veterans and ALS. So there's some sort of risk factor that being a veteran makes you risk factor towards ALS. So we'll talk about that and other risk factors, and how that knowledge came about. All these studies came about that showed this. And then I want to talk about how the VA took this information and wanted to do the best that they could possibly do to care for veterans, because ALS is a very difficult disease to manage. It requires comprehensive care, as we all know. And so the VA took it upon themselves to model the best models out there, and I think that's what we've done. And then finally, at the end, I want to share some information about my clinic and the clinic that we've set up, and just some of our statistics and what our makeup is, and what we do, and things that we offer. So before we get into talking about specifically with ALS and veterans, kind of have to put this in perspective of what are the risk factors of developing ALS in a general sense, not specifically for veterans, but in a general sense, the primary risk factor is just being older. It's well known, ALS is not a disease of the young, it's a neurodegenerative disease, and so being older is your main risk factor, and the age of onset across the United States is in the late 50s, early 60s. Men are a little bit more at risk of developing ALS than women. So there's about 63 to 37% ratio of male-female. ALS is not known to be a strongly hereditary disease, although about 10% are considered hereditary. So that means there is a clear-cut gene that is abnormal that gets passed down to generation, or has the potential of being passed down. But that means that 90% of these cases are sporadic. So there's something that happens, your lifetime accumulation of exposures combined with a complex of your own personal genetic makeup, that accounts for 90% of the cases. So we call those sporadic cases. Head and neck trauma is to be a known risk factor for ALS. Tobacco use, tobacco makes you about 1.5 times more likely. Excessive physical exertion, this is a big tomato out there that still doesn't have a clear-cut answer. This has been looked at back in studies back in the 60s and 70s, and they look at Italian soccer players, and they thought, well, if you're a high-level athlete like this, you have a higher risk of developing ALS. And the next study comes out and disputes it, and this went back and forth. And then there's all these big-name professional athletes, football players that develop ALS. Lou Gehrig was a football player in college, and he's very well known for his professional baseball career. So there's a big question. What does physical exertion do that doesn't make you more at risk for ALS? And this was a big question mark until a study came out this last year that showed they looked at this, and they showed that those that are at the most highest extreme of a lifetime accumulation of whatever they do, physical exertion, whatever they do, and those at the lowest extreme of being sedentary, these are the ones that are highest at risk. Those in the middle, where you're getting a moderate amounts of exercise, you have the lowest risk. So there might be some truth to this. I personally believe this needs more looking into, more studies. But we're going to leave it on the list of possible risk factors. Military service, this is what we're talking about. This is the rest of my talk, and I'm just going to tell you right now, we don't know why. So I'm just ruining my talk right now. We don't know why military veterans are at higher risk of developing ALS, but it's on the list, so we'll talk about that. And then there's this other category of speculative things that this kind of falls in the category of that accounts for the 90% of sporadic cases, where it's just a combination of lifetime exposures, whether your job caused you to be exposed to certain things, or you just where you lived or whatever. It's just a lifetime of environmental occupational things that you do that that make you more at risk. And some of these things, really deserve another half an hour discussion about, like this cyanobacteria exposure. It's a blue-green algae, and it creates a toxin called beta-methylamino L-alanine, or I'll just call it BMAA because that's what everyone calls it, BMAA. It creates a toxin that has been discovered to be a known risk factor when it accumulates in certain amounts. But this isn't to freak you out, because this is a blue-green algae that's pervasive in the environment. We're all exposed to at some point in our lives, and just because you have exposure to this blue-green algae doesn't mean that you're going to get ALS. Everyone on Earth is exposed to this algae. So who knows what the real significance of that is? Pesticides, fertilizers, these have always been linked with neurodegenerative diseases. Heavy metals, formaldehyde. That came from a study with funeral directors that use a lot of formaldehyde in their work. So these are other things that people do in their life and their occupations that are known to make them more at risk of ALS. So why veterans then? This is the golden question. The story of ALS in veterans starts with the first Gulf War. And all these young, healthy service members, presumably in their 20s and 30s, maybe 40s, all throughout the decade of the 90s. And some of them are developing ALS. And it's an unusual thing for a young, healthy person to develop at that age of their life. And so it took notice. And the Secretary of the VA started noticing this. And by December of 2001, he says, we got to start looking into this. And we got to have this on our radar so that we can be prepared when this really comes down and gets proven. If it's proven or not, then we're prepared for this. So these two pivotal studies, this is what did it in 2003. And it was this first one that's called the occurrence of ALS among Gulf War veterans. So it looked at service members that were deployed to the Gulf War, the first Gulf War in the early 90s, versus those service members that did not get deployed. They stayed back in the United States. And those that were deployed to the Middle East were nearly twice as likely to develop ALS as those that not deployed. And then the other study was excess incidence of ALS in young Gulf War veterans. So this now looked at those service members that were deployed to the Middle East and compared them to an age-matched control of regular civilians, non-military, the general population. And it found that the Gulf War veterans were 3 times as likely as the general population of the same age matched. So there's something there, and it's something to do with, they went to the Gulf War and served during that early 90s Gulf War in the Middle East, but also on top of that is something about being in the military that makes you more at risk of developing ALS. And next study that came out was 2005, and it said it wasn't just the Gulf War vets. This is a study and they actually excluded Gulf War vets. So they looked at military service from 1910 to 1982, and they collected data from 500,000 veterans. And what they found was that compared to civilian non-military, the veterans were 1.58 times at increased risk of just having any military service. And if you serve during a wartime, then you increase your risk. If you serve during 2 war times, you increase your risk more, and so on. So there's a clear-cut association with serving in the military and serving during war times. It didn't matter which war you served, if it was World War II or Korea or Vietnam. Of course, they didn't look at the Gulf War veterans. And this increased risk didn't matter on which branch of service. So they also looked at Army, Navy, Air Force, Marines, Coast Guard. They looked at all these branches, and it didn't matter which branch you were in. It didn't matter how long you were in or which areas of the world. Because you might think, this person served in Southeast Asia, this person served in Europe or Middle East or Africa. None of that mattered. All that mattered was you served in the military, and your risk was slightly increased if you served during a wartime. So that was the study that did it. These two, and then the other two from 2003. So what happens next? Now, so we have the scientific body of literature saying this, but the VA has got to do something about it now. It doesn't automatically mean, well, the VA can just say, all right, here's your disability. And there's a process. There's a process that the VA has to go through where now the literature has to be reviewed, and that has to go through Congress, and it's a very formalized kind of thing so that the VA can formally recognize this as a potential disability and start really taking care of these veterans properly. So that process starts with the National Academy of Sciences, Institute of Medicine. They've got to confirm this epidemiological connection here. So they did that, and that was 2006. They published their ALS in Veterans, a review of the scientific literature. So that was the first formal step. So now the issue can get debated by Congress, and there's certain congressmen that sponsor this bill, and there's advocates of the bill. The Paralyzed Veterans of America are important. They were an important advocate, and various service organizations. The VA was a big part of trying to push this bill through Congress. And so none of it happens fast. So I'm putting these time scales. It's 2003, the first studies, now it's 2006. Finally, 2008 was when everything got pushed through, and the VA says, yes, we formally recognize ALS as a service-connected disability. So what does that mean? It's a service-connected disability. And so you'd say, you know, a veteran serves and they get disabled because of their service. So now the VA should take care, the government should take care of it. And this idea of disability, it goes back to the colonial times. There's legislation that was written into the Rhode Island legislation that talked about this. And then it's all been modified throughout time. But with something like ALS, it isn't a clear-cut thing that you did. If you got wounded in battle, you lose your eyesight, you can't work. Now you get disability rating for because you can't work. But with other things, like, these presumed service connection illnesses, I'll bring up the example like Agent Orange is a big one. They found that Agent Orange makes you more likely to develop cardiac disease or diabetes or Parkinson's disease. So those Vietnam veterans that were exposed to Agent Orange, if they've developed Parkinson's disease now they get a little bit of service connection illness so that their care can start being paid for by the VA. So this happened for ALS in 2008, and it was formally recognized as an automatic service. So you get diagnosed with ALS, now you have automatic service connection, and your care can start being taken care of at VAs, and you start getting a disability financial benefit. That benefit was increased to 100%. So when we say 100% service connection, that's the holy grail with VA disability, because that gives you all of your medical care, every aspect, whether it's a skin condition or whatever. From then on point, all of your care is covered from the VA, and you get a monthly stipend. So that happened in 2012. So from the first time it was reckoned, the VA, the Secretary of the VA in 2001, now it's 2012. It takes that long for these things to happen. And now veterans with ALS are getting fully connected with their service connection and taken care of by the VA. So once that service connection bill went through, now the VA is saying, okay, we're gonna have to be dealing with a big deal here, because ALS is a complex disease, and we gotta do this right. So it's not just like treating diabetes where you go see your doctor and you can get a medication. And ALS is a multi-systemic, multidisciplinary kind of disease that there were clinics that were, these ALS clinics are excellent models, and the VA wanted to model that, and they also needed to figure out where to put these clinics, and so they had to really study where the best places throughout the country to put these clinics, and how to put these clinics together. So So finally, by 2014, that's when they published their directive, their guidelines, and this was the manual that set out all the requirements for ALS care at all these regional VA centers. Now, when the VA looks at the United States and all these regions, they talk about these VISNs, V-I-S-N, Veteran Integrated Service Networks. And here's a map. Here's a map of the United States. These are all the regions of the United States. So here we are in Region 12, VISN 12. And so the VA said that each region will have at least one ALS center. And depending on the population of veterans or how the studies show, if there's more ALS cases in certain regions, then they'll have more ALS centers. For example, Florida is a big retiree area, and so they have 3 ALS clinics, VA ALS clinics in Florida. In Region 12, where we are, the numbers and wherever all that data determined that we would have 2 ALS centers at VAs in Region 12. So Hines, they determined would be one of those centers, and Milwaukee. So you can kind of look at this map, and some regions are smaller. This is all based on population density where veterans tend to retire. Look at here in Region 19. It's a big area. It's almost 1/50 the size of the United States. And I don't know how many ALS centers are in Region 19, but it's a big area. And if you live up in Montana and you're the VA ALS centers in Denver, I don't know, you probably just get your care in the civilian world. So the VA really wanted to recognize the best way of treating ALS, and they took the model of all these civilian ALS clinics, and it's this multidisciplinary approach to care. And it wasn't new. These civilian centers have been doing this since the 1980s. And it's the goal of palliative care, which basically means trying to improve your quality of life as best as we can. You know, we know we can't reverse or stop this disease, but we can improve your quality of life. And that's the idea of palliative care. But what they found when they started looking at these ALS clinics is that they're doing a little bit more than just palliative care. There's an Irish study in 2003 that said those ALS patients that follow in ALS clinics actually survive better. Their survival was 7.5 months longer than those ALS patients that were not following the ALS clinic. So if you just saw your neurologist at one place and saw your physical therapist in another place and all this disjointed care, that led to worse outcomes than if you went to an ALS center and got all your care at that same place, and all your care was put together and everyone talked together, and that actually caused your survival to be advantageous. Now, if you had bulbar onset, what that means is your first symptoms when you developed your ALS was either speech or swallowing or tongue movement problems, then your survival was even better. That was 9.6 months longer if you attended an ALS clinic. Another study in 2014 showed that your survival was 1.2 years longer for those that attended ALS clinics. So I don't know what's the difference between 2014 and 2013 and 2003, other than maybe we just learned how to do things better, or maybe something with the studies. I don't know, but something was better. Well, and the bottom line is that these ALS clinics are actually the best way of managing ALS, and you can really have improved survival just by attending an ALS clinic. So that's what the VA wanted here. I started at Hines. I took this job in 2012, and at that time we knew that Hines was going to be named the ALS center for our region, so we had to start preparing. So we just started an ALS clinic, and this is my little shout out to Megan, our speech pathologist. I approached her, and her boss at the time was Barb Cook, and so we called ourselves an ALS clinic. But that gave us time to put the rest of the services together. It takes time for everyone to rearrange their schedule, And by 2014, when that directive came out, we were full out on running out with it full out, so that we had a full services of all the services. So fast forward to current times. This is basically how we've been since 2014. We've always had our clinic on Tuesday morning, and we see about 3 patients per morning, so it equals about 12 patients per month. It consists of a neurologist, there's a social worker, a speech pathologist, a dietitian, physical therapy, occupational therapy, palliative care. It's pretty much the same model as the other ALS centers across the country. And you got Les Turner or the others in the city of Chicago. For pulmonary care, we have a pulmonologist that commits his career towards neuromuscular pulmonology, but he doesn't see the patients with us in clinic on Tuesday mornings. He has his own clinic schedule, so unfortunately the patients have to come back a different day and see him. We have pulmonary testing that can be done on Tuesday mornings, and it's just on a different floor, so they go up to the pulmonary lab for that, and they can get their respiratory equipment for that. Other services here at Hines that are available on request, and these aren't part of the formal criteria, but we found that these are helpful things to have as part of a multi-disciplinary clinic at a large medical center. So we have mental health, psychology resources. There's physical medicine and rehab doctors that we can consult for specialized orthotics for your limbs or neck braces. We have a rehab engineer who helps out with advanced technology in the home. Our prosthetics department does all the medical equipment orders. And I mean, the prosthetics department is fast with any order that I put in, but especially with ALS, they prioritize the ALS orders so that those orders are done and fast, so that there's no delays with getting the medical equipment. We have a driver's rehab department. These guys have a role in helping the veteran get the right modified van, so that when they get their power chair, the VA pays for getting a modified van, and so you can't just have any van. You can't just load your chair up in the back of your pickup truck. It has to be a very specialized van that we don't want you to get the wrong thing here. We want you to have the right proper equipment, so that you have the right specifications, the right height of and doorway entry, and the right frame that is stable enough and braking ability. So that's what these drivers rehab. They're specialized in knowing all these things, so that then they can give the veteran a list of things and say, okay, now go and take this to your dealer and say, you need this, and you only get your van if the van has that, and you're not getting some chintzy thing. GI services, we have a GI department that's very helpful with planning feeding tubes and maintenance of care of the feeding tube. We have respite care services. So any veteran that's 100% service connected, like ALS veterans are, they have access to up to 30 days of respite care a year. So most of our veterans are living at home, and their caregiver, spouse, or whatever is their caregiver. But sometimes the caregiver needs a break, or they have to travel and take a vacation or go cross country. And so the veteran at home needs respite care. And so we have an extended care center that we can either put them in for a week or so, or most of the time it happens where we contract out with some nursing facility and the veteran goes, and we pay that nursing facility to house this veteran for respite care. I'm hoping our PVA reps are online here, because I've got them in bold, and I can't say enough about the Paralyzed Veterans of America reps that help these veterans out, because if it weren't for these guys, it would take years and years for this service connection disability to finally push through. But these guys get this service connection rating within weeks, and it comes back, and then they help them with getting all these grants that I don't know about. These PVA Robert and Winston, they help with all these grants, and they help so much that it all happens beyond my control. And so the veteran will ask me, well, what about this grant? And I don't know. You have to talk to Robert on that, because he does it all on his own and all outside my control. So these guys are extremely valuable to the veteran, and helping them pay for all these grants that is necessary for the benefits. There's community ALS organizations. Some of our veterans follow with the ALS Association, or Les Turner, like we're talking. We started, since the pandemic started, we've done some video telehealth. We've designated our first Tuesdays of the month as our video day. So the rest of Tuesdays are our face-to-face clinics. But this, we found that this has been really helpful for those veterans that just live too far away and just can't, the travel is just too burdensome, or they're bedbound at home and they just can't get out anymore. It allows us to stay in touch with them and still provide care in a way that we weren't able to do until the pandemic pushed us to do this. Okay, so just some interesting numbers about the clinic that we've set up here. Since we started in 2013, we've had 128 total patients, and we have 28 that are actively being followed. 124 of those are male, 4 have been female. And I think that ratio just represents the veteran population. 6 have had positive genetic testing. If you remember, I said earlier, 10% of all ALS is considered to be hereditary. So our numbers are a little bit less than that. 4.7% of our numbers are actually genetic. Average duration of illness, I found has been 3 years and 3 months. Longest duration, I have a patient that still is going, he's at 25 years of having the illness. 4 of our patients have had it for greater than 10 years. If you remember, one of the risk factors I said was head trauma. And if you think of veterans, they all must have had some exposure to trauma or combat, and that's not really true. I mean, 31 of my patients have reported some sort of head trauma, so that means 99 have not. So I don't know if this is, I don't know if you can say this is their true risk factor for developing ALS. It's something else. It's something beyond the normal risk factors that is giving them ALS. So average age at onset of our veterans has been 67.2. And if you remember, I mentioned the average age across the United States is always like the late 50s, early 60s. So it's a little bit older than the civilian population. Here's my age range. I broke it down. I did have one person present in their 20s with ALS, a couple in their 30s, but overwhelmingly, you can see most of the patients have presented in their 70s or 60s. So this 60s and 70s is really represents most. But so it's an older than average than what's average in the general population. Branch of service. If you remember from that 2005 study, I said that it didn't matter what branch of service you're in. Ignore these numbers down here at the bottom for now. These are my numbers. So out of my 128 patients, 73 have been Army, 25, so 57% have been Army, 19% have been Navy, 13% have been Air Force, and 11% have been Marine Corps. I don't have any Coast Guard patients, so I'm not leaving out Coast Guard. I just don't have any patients. So I don't know, what's the meaning of these? I don't know. I included these numbers right here. This is percent of overall military. So Army personnel is 36% of all military. So, and Navy personnel is 24% of all active duty military. So these are the real numbers of just personnel that are serving in the military right now. So what does this mean? I don't think it means anything. It's just interesting numbers that I like to present. It probably just means that in the Great Lakes region, there's probably more Army veterans that have retired. If you looked at VA ALS clinics on the coast in Bethesda or San Diego, you probably have more Navy veterans. I mean, this really doesn't mean anything until you include all the numbers across the United States, and then you can start looking at percentages. But I don't know, I just throw these numbers out just out of interest. Some specific things of how we've treated. 26 of those 128 patients have received Radicava. But remember, Radicava has only been out since 2017, so 26 have received it. 65 have received the G-tube, so that's exactly 50% have decided to get a G-tube. 6 patients have opted for a tracheostomy for respiratory support, so that's 4.6% of the patients. All right, so how do we treat ALS? And this isn't any different than any other ALS clinic. We all do the same thing. And what are the things that are meaningful that actually slow the course of the disease? When I said that initially the goal of the ALS clinic was palliative, to improve quality of life. That is the main primary goal, but we found that there are things that we do in our clinics that actually slow the course. And the number one thing, if I make any impression on any of my patients, it's respiratory supports. And using that BiPAP and using your cough assist machine. The one study shows that those those ALS patients that use BiPAP versus those that don't use BiPAP, the ones that use it have a survival advantage up to 15 months. That's huge. That's when you talk about comparing these to the actual medications that we use. This is far and above the most important thing. So in the clinics, it's your pulmonologist that's your most important person there. A little shout out to Dr. Wolf and Coleman if you're listening. Your pulmonologist is way more important than your neurologist. Number 2 on that list is still not the neurologist. It's the stabilization of weight and adequate caloric support. So another study showed that when you put the G-tube in, you get a survival advantage of 10 months versus those that don't get the G-tube. So number 2 most important is the speech pathologist and your dietitian that help decide whether you need the G-tube and when to put it in. And me, I just do what they say. I know everyone likes to say, oh, Dr. Kvarnberg, he's great, but really it's a team effort. It's the pulmonologist that's important. It's the speech pathologist and the dietitian and physical therapy and occupational therapy and social worker. Number 3 on this list is drugs. So these are actual medications. Everyone focuses on the drugs and research is on drugs and that's great. I can't wait till we get a medication that stops this disease or reverses it. But right now we're just not there. And when I say stopping the disease, I'm talking about a disease modifier of that motor neuron loss. Something that actually attacks the pathophysiology of the disease and preserves that motor neuron. So we take Riluzole. That Riluzole has been around since the 1990s. And every time we study it, we know that it preserves, it prolongs survival by 3 months. That's a number that you can always pull up from it, 3 to 4 months. In 2017, Radicava came out. And so they didn't study Radicava in terms of prolonging survival. They studied it. All these ALS drugs now get studied by using this ALS functional rating scale. So it's a research tool that you can track over time how well your functioning is. So it's a 48-point scale, and you can grade how well your speech is and your hand function and how well you're moving with walking or going upstairs and breathing, all these things. So all these things total up to 48 points. So when they studied Radicava, they found that those that got the drug over 6 months ended up being 2.5 points better than those that didn't get the drug. So on a 48-point scale over 6 months. So it does something, but still it doesn't, that is about as equal, I think, as Riluzole as far as effectiveness, and they pale in comparison to number one here is 15 months of survival advantage by using your BiPAP. That's the most important thing that we got to focus on, I think. So the rest of what we do is supportive care, and this is what I mean by palliative or improve your quality of life. So there's other medications that we use to treat symptoms. We can treat excessive saliva with amitriptyline, glycopyrrolate, scopolamine patches. We refer for Botox if none of those things happen. You get Botox into your salivary glands that helps dry up the. There's something in ALS that happens called pseudobulbar affect, and it where you get this labile mood where you laugh easily or cry easily for no particular reason. No, it's just a symptom that happens with other neurodegenerative diseases, and there's a medication that works for it. It's called Nudexta. We use muscle relaxants for cramping and stiffness. Constipation tends to be a problem with a lot of ALS patients, so we make sure the bowels are moving with laxatives. Speech therapist is there to provide assistive communication devices using either very low-tech means of paper and pencil or a writing pad, or real high-tech things where they type out words on a Dynavox and it talks for you, or even higher tech like an eye gaze machine, or there's even high-tech machines that can combine your iPhone apps and combine control over electronics within your house. Speech therapy also monitors your swallow function with video swallow studies, and they provide valuable input of dietary recommendations and when a person needs to have the feeding tube. So I really listen to what they say with that. Mobility is dealt with by the physical therapist in the clinic. And so when someone thinks, oh, I'm getting physical therapy in the clinic, it's not they're training you how to be stronger. The physical therapist is a mobility expert. So she's trained by the spinal cord rehab institutes that we have here at Hines. And that's what she does. She deals with mobility. So when she sees you in the clinic, she's concerned with how well you're using your walker, what type of manual chair or power chair that you get, if the power chair needs repairs, and make sure that you can function well and change the angles of the power chair to relieve pressure on your areas. And we get hospital bed and Hoyer lift and training on the Hoyer lift, shower chairs. All these things are meant for you to have at home and improve your quality of life when you lose your mobility at home. I talked about grants. The PVA helps to get grants that all happen pretty much beyond my control. Like I said, the PVA guys, they just do all these things automatically. So grants that to provide access into your home, whether it's a ramp or a lift. There's grants that provide home modifications to alter your bathroom, alter your living spaces, doorways, so that you can move around safely, remove carpet. There's, on the lower tech scale of this, there's home safety equipment like grab bars and stair glides and that kind of thing that we can provide. I lump occupational therapy and rehab engineer kind of together. They work together to help you function better at home with either low-tech things like wrist splints and specialized utensils to toilet seats that are elevated, bidet, bedside commodes for help you using the toilets, specialized doorknobs, automatic door openers, and it gets even more using more technology. There's specialized mounts on your electronic device. There's head controls. If you lose control of your fingers, that can be mounted to your chair and computer. All these dictation apps like Dragon or Alexa can be added to your computer that help you control your electronics in your home, whether it's your thermostat or your lighting or door locks. And all these things can be remotely controlled with apps on your home that the rehab engineer helps put in. So there are services that we contract out with various agencies. So we don't have actual VA employees going out and doing physical therapy in the home, but we contract out with agencies if if like we feel like they would benefit from real physical therapy or occupational therapy, so ongoing kind of things. They're different from what they would get in their regular clinic visits. So physical therapy to help you improve your gait techniques, and occupational therapy to help improve your range of motion and that kind of thing of your limbs. Other services that we contract out is an infusion nurse for the Ray Cava. We contract out for home health aides. They get an aide up to 15 hours a week. The VA doesn't have actual VA employed hospice personnel, but we contract out with hospice agencies, and we've had very good experience with those agencies, especially with how they supply their respiratory therapy and respiratory support when the veteran is hospice ready. So we've had very good reports about these hospice agencies so far. All right, so wrapping this up in my last slide, it brings us back to the question of why vets. And like I said at the very beginning, we don't know why veterans have a higher risk of developing ALS. What we do know is that from the studies that were done, it's not confined to certain exposures in certain areas of operation in the world. So like I said, just because you served in the Middle East or Southeast Asia doesn't mean you're more at risk. It's not related to the branch of service, possibly related to serving during wartime years. Other possible risk factors and exposures, and you try to think about what is it that all veterans are exposed to more so than the general population. And I don't know, we're not there yet with understanding that yet. I mean, you can try to think of, well, are there environmental contaminants? Like when you fire your weapon, is there heavy metals or aerosolized lead in that ammunition or gunpowder? You know, it's right in front of your face, so you're firing your weapon. But then you look at those branches of services that fire the weapons every day, like the Marines or the Army, and it goes back to, well, there isn't a branch of service that gets ALS more, that's all equal. So kind of throws that one out. Pesticides, insecticides, who knows? These are all just speculative things that tobacco use. I don't know that we can say that veterans that develop ALS are more prone to be smokers. I don't think that's true. Excessive physical exertion, I don't necessarily believe in that, or trauma. Like I said, I have 31 vets that have reported to me out of the 128 that have had head trauma. So there's something else there. It's not overwhelmingly most of them, and I don't believe that these veterans are throughout their entire life have experienced excessive physical exertion. I don't think they fall into that category on the excessive end. So it just leaves us with a whole bunch of question marks, a whole line of question marks at the end. And it's been yet to discovered why veterans are at higher risk of developing ALS. So that's my last slide. I think I finished in time here. A few questions if people have, or a few minutes if people have questions.
Yeah, we do. Thank you so much. That was really helpful, and it was really nice to see the breakdown of what your clinic looks like and understanding the very personalized work that you do with families. And we did have some questions that came up, so I wanted to I know you had a lot of question marks towards the end around what is this connection, but one of the questions was military connection athletes. Is there any evidence to show that the connection with sudden muscle growth, like for example, preparing for a marathon, is associated?
I don't know. And like I was saying with this whole physical exertion thing, that's been a big question mark that's gone back and forth with the literature. And until this last year, when this study came out, that those that had the most extreme physical exertions accumulated throughout their life. So when you talk about training for a marathon, well, and that's pretty extreme physical exertion, but if you're just training 1 year and you've never done that, or are you training every year? And so, yeah, that's a tough question.
Yeah. I have another one here that's, I think, a tough one too. Is there any data on the portion of VA ALS that is related to TDP 43, ALS versus chronic CTE, tau and ALS, similar to the distribution seen in NFL players with ALS?
That's an excellent question. And yeah, I didn't talk about what's happening on the pathophysiologic scale of what's happening to that motor neuron. And TDP43 is a protein that we all have in our cells, and in motor neurons is particularly important because it helps transport materials down that long cell. And so we know in studies of trauma on motor neurons, when they isolate a motor neuron in a lab, when you give trauma, then bad things happen to this TDP43 protein. And I think that's also the link with tobacco use. It interrupts this TDP43 protein. So the question of CTE, chronic traumatic encephalopathy, that also has shown abnormal modifications of this TDP43. So that's probably the link with trauma and ALS and TDP43. I think it's all related. And then there's these studies on CTE. They did look at motor neuron disease as part of their little side studies, and they did show that the TDP43 was most abnormal in their side studies of those that had ALS in those patients that also had CTE. How does this relate to veterans? I have no idea. I don't know. There's just, they're very hard to study these things.
Yeah, it sure is. Yeah, and you know, that just gave me an idea of, we have some folks at Northwestern who are looking at trauma, that maybe we'll invite them to be speakers in their next series to help them with that. You know, one of the comments from a person was saying that the travel to these ALS centers is quite far for veterans. So I think that the telehealth is probably really helping. And then another person, same person, mentioned that he went through the PVA when he applied for ALS benefits from the VA. They told me that possible or probable ALS are not approved, but definite ALS is. Is there any VA guidance on the use of these terms?
Well, I think if someone has given a diagnosis of possible, probable, and the PVA rep is like, well, you know, we can't do anything with that, then they go see the ALS specialist at the VA center, or their ALS specialist at these clinics, and that diagnosis can be clarified with, you know, we have certain diagnostic criteria that puts you in a category of probable, possible, definite. And so, yeah, I mean, the PVA guys, their hands are kind of held when they're presented with a possible diagnosis. But yeah, I'd say my answer is that diagnosis can be clarified by an ALS trained neurologist, and certainly will be clarified over time as the disease presents itself better.
Thank you. And so I guess the answer is it's worth re-exploring in order so you can get that full coverage.
Yeah.
What portion of ALS people with ALS in the VA get home-based primary care?
As much as I want, or as much as we can. We have an excellent home-based primary care department here, and if all of our patients wanted it, I would consult home-based primary care. So, but I didn't look at that and include that in my numbers. I would say about half of our patients getting it. But if they all requested it, I would give it to them all. Yeah.
I mean, it's just unbelievable what the VA offers, and that's always the first question out of our support service coordinators when we meet newly diagnosed folks is, you know, are you a veteran, and really connecting them with the PVA to get the process started if they are. This other question asks, if a veteran is found to have a positive gene leak, will they still receive their benefits since it may not be related to service?
I'm sorry, a positive what?
They have a positive genetic test.
Oh, no, that doesn't matter. They have a diagnosis of ALS, and regardless of it's genetic or sporadic, it doesn't matter. They still get their 100% service connection, and we'll still have them in our clinic. Yeah, because like I said, we've had 6 of our patients that have had positive genetic testing. So
yeah. And we know that, more and more families are wanting to have genetic testing that don't have the familial known mutation. And so it's been really interesting to see as that changes over time and what that looks like. I think it will really help prepare us as we go into looking at for the future for clinical trials.
Mm-hmm.
Another question was, what portion of ALS patients in the VA receive riluzole?
Receive riluzole?
Riluzole, yep.
I would say most, almost all of my patients, unless there was a specific reason that they had side effects or they just prefer not to take it. But I would say greater than 95% of our patients are taking riluzole.
So another question is around Nuedexta, or what portion of ALS patients in the VA receive Nuedexta based on the clinical trials showing improved swallow and speech? Is there a difference between, let me see, make sure I can read the full, improved speech. Do you know the answer to that question?
Yeah, I'm aware that there are studies showing that Nuedexta is kind of a disease modifier. It is considered that way, but I use it purely when there's symptoms of the pseudobulbar affect, the Lewy moods. It's a non-formulary on the VA, so I have to submit a request and say that it's used for pseudobulbar affect, and then the pharmacist approves it. So I don't prescribe it for everyone, only when I feel like that I can justify it for their pseudobulbar affect. And how many of my patients? I would say maybe a third or fourth. I'm just guessing.
And then, this other question is related to, does the VA provide all the home gadgets, or is it just the info to purchase out of pocket?
I encourage my patients not to purchase anything. If they feel like they have a need, they can contact us. And I've had a lot of patients email me some link to a website and say, can I get this? And usually I say, well, yeah, let's try to get it for you. And our occupational therapists and physical therapists are very open to supplying whatever it is that the patient needs. So I really try to tell them, don't buy stuff on your own, because we can buy it for you.
Yeah, I think that's really important, and we've seen that to be really helpful for families. And again, in April, we'll have folks from the PVA, Winston, and Robert Statham talking, so they can kind of go over a little bit more about those specifics. And then let's see, there's a lot more questions, but we're wrapping up, so I will make sure that I answer these for folks offline the best that I can. There's just also some really beautiful comments saying, thank you, you took care of our mom. We really appreciate your time today in helping us better understand, your clinical practice and within the scope of the VA. And I think veterans really appreciate that care, and it's care that is important because it improves the quality of life so much. So I just really want to thank you again for being with us here today. And for folks, the questions that I didn't get fully answered, I'll do my best to get those offline and ask Dr. Kvarnberg if he can answer some of those for us. So thank you so much, and I hope everyone has a lovely week, and we'll see you later.
Okay, thank you. Thank you for letting me.
Okay, and I'm just going to walk you through a little bit more. We have 2 upcoming events that are happening. We have our Making Activities of Daily Life Easier. That's going to be on March 17th with Becca Schroeder. And we also have, again, on April 28th with, like I mentioned before, Robert Stadham and Winston Woodard from the PVA, as well as having Shelley Hoover, who I'm so excited to have join us. She's from the IMALS veterans team, which they're doing really remarkable and amazing things to help push the legislative agenda forward and ensuring that people living with ALS and veterans living with ALS get the care that they need and access to clinical trials. So thanks again, and I want to thank everyone for walking us through this very special topic, and we will be posting the full Baba Ives video to share on our website, as well as we'll be sharing some of that on social media as well. And thank you for spending your day with us today. I really appreciate it, and please take a moment to fill out the surveys. It really helps guide the direction of care that we're taking. So thank you so much.